Good afternoon. I'm Jill Lowery. I am Chief of Ethics Policy at the National Center for Ethics in Healthcare with the Veterans Health Administration. I am also on the faculty at Duke. I'm going to talk to you today about an initiative that we've implemented in VA to promote the patient-centeredness of the care that we offer to our patients who have serious illness. We've known for a while that too often goals of care conversations are happening late in the course of illness. We've had situations where people end up in the ICU and nobody has actually started talking to the patient about their goals of care and about what they would want if there was a sudden acute event. And so we know also that there's been a lot of work done for a lot of years on advance directives, and we know that that isn't enough. Even if the patient fills out an advance directive, it might have been in their lawyer's office or outside of a conversation with their healthcare provider or their healthcare team about what's most important to them and what this means in the context of their illness. So with the Life-Sustaining Treatment Decisions Initiative, we have developed a new national policy that covers all of our VA medical centers. We have roughly 150 medical centers and over 1,000 outpatient clinics to standardize practices around eliciting, documenting, and honoring patients' goals of care and their preferences about life-sustaining treatments. These goals of care conversations now are required in VA for high-risk patients. And we define a high-risk patient as any patient who is at high risk for a life-threatening clinical event in the next 1 to 2 years. So we're not talking about having a goals of care conversation at the point you refer them to hospice, but further upstream, earlier in the course of illness, beginning to normalize that discussion about what's most important to the patient and then wrapping care around that. It's not enough to just pass the policy. You also have to support implementation. And so we also developed new tools in our EHR to make sure that this information was easy to find in one click. So now from our cover sheet, you can access documentation of that conversation that documents the patient's goals of care and their life-sustaining treatment plan right from the cover sheet. And if there's been any change, you can place an addendum onto that note so that it's a continuous living document. The other thing that we had in our EHR that we developed is a new set of durable orders that default to the top of the Orders tab. So with one click, you can be at the Orders tab and you can see the durable orders for the life-sustaining treatment plan, not just about code status, but if the patient wants to make any limitations to things like feeding tubes or mechanical ventilations or transfers to the hospital or transfers to the ICU. So that information is now in our medical record, very, very easy to find. So we also knew that you can't just have a policy and you can't just have an EHR tool. You also have to make sure that the clinicians really know how to have high quality conversations with our patients. And so we developed a Goals of Care Conversations training program that I'm going to talk a little bit more specifically about that we have rolled out, not just in oncology, but across our system for clinicians who take care of patients with serious illness. And why do we need to do this? Our people are smart, they know how to talk, they know lots of facts. But I put this study up here from the Journal of Palliative Medicine in 2012. This was Tony's group that did this work, and it's a beautiful representation of what the problem is. And so if you look at clinicians' ratings of their own competence with communication skills around issues of the end of life, and you compare that with the patient's rating, there is seriously zero relationship. It looks like somebody sneezed. And so just because you think you're good at it doesn't mean that you are. And just because you think you're not good at it doesn't mean that maybe actually you've got some pretty good skills. One of the things that this study pointed out, which actually maybe even scarier, is that they also had the attendings rate residents and fellows skills. And on 2 of 6 measures, Only on 2 were those in any way related to what the patient said about the clinician's skills. And on 0 out of 6, there was a relationship between what the family said about the clinician's skills and that attending's rating. So even our supervisors, people who are teaching our residents and our fellows, aren't always accurate in terms of assessing how skilled this person is from the perspective of the patient. So we know many people have never had any kind of formal training in how to have these discussions with patients, and so we needed to do that. So rather than reinvent the wheel, we worked with VitalTalk to develop a training program that was easily disseminatable. And so we developed a total of 5 interactive modules. Each is about 45 to 50 minutes. Believe me, we talked a lot about how long that this would take. And so we developed these into modules that are flexible, that could be delivered over a series of lunch and learns and divided up so you don't have to do them all at once. We also then adapted this training for nurses, social workers, psychologists, and chaplains because we know they're a very important part of the team too. And part of those adaptations were made to customize for scope of practice and to add a segment about how the team can work together to make sure that these patients are identified, who's going to make the appointment, how are we going to prepare them for that discussion, and how to do those handoffs back to the provider. We've had really high ratings from this training, both immediately as well as with our RN social worker program. We've been doing follow-up surveys at 4 months to say, okay, you had this training. How well have you actually been able to incorporate this into your practice, and what differences have you noticed? We're just beginning that 4-month post follow-up with our physician, nurse practitioner, PA training as well. Nationwide now, we have 765 clinicians who've been through our Train the Trainer program. It's a 2.5-day program where we teach them first the communication skills, and then we teach them how to teach this course in a psychologically safe manner. The expectation is that that clinician goes back to their home facility and does at least 3 training sessions for each of 3 or more years. We now, because of our new medical record tools, are able to track how many goals of care conversations have been documented in our medical record in real time. As of the 1st of February, we had over 121,000 patients now with goals of care conversations and life-sustaining treatment plans that are accessible from the cover sheet. One other piece of good news is all of these materials are available for anybody to use. They were developed with taxpayer dollars. I've put the link up there in case anybody wants to access those materials and look at those. The link takes you to the program for physicians, nurse practitioners, and PAs. And if you scroll down the page, you'll find the link to the corresponding nurse, social worker, psychologist, and chaplain training program. We're really excited about the training. People tend to really love it. You know, sometimes when people have to come to a training and they're kind of grumbling at the beginning, but by the end, when they're saying, you know, this is the best training I've ever attended, I loved it. It's really been gratifying to be a part of it. So, thank you.